From the JAMA Network, this is JAMA Clinical Reviews, interviews and ideas about innovations in medicine, science, and clinical practice.
Hello, and welcome to our listeners around the world. You're listening to the JAMA Clinical Reviews podcast. Thanks for joining us. I'm your host, Dr. Karen Lasser, Professor of Medicine at Boston University and Senior Editor at JAMA. Today, I am joined by Dr. Kevin Hill, who's an Associate Professor of Psychiatry at Harvard Medical School, and we'll be speaking about therapeutic use of cannabis and cannabinoids. Welcome, Dr. Hill, to this JAMA Clinical Reviews podcast.
Thank you for having me, Dr. Lasser. It's great to be here.
It's our pleasure. So, to begin with, could you define some key terms such as cannabis, cannabinoids, and cannabidiol? I hope I'm pronouncing that right, CBD.
Sure. No, you've done well. So when we talk about cannabis, we're referring to the cannabis plant. So it's a complex plant that contains hundreds of chemicals. So it has flavonoids, has terpenes, and it has cannabinoids. So cannabinoids are compounds that are specific to the cannabis plant. We typically talk about two of them. So delta-9 tetrahydrocannabinol, THC, and CBD, cannabidiol. However, there are over 140 cannabinoids. So I think that as much as we know about THC and CBD, we're just scratching the surface in terms of cannabinoids and the cannabis plant as a whole.
Which of these substances cause the high that's associated with marijuana? Which is the psychoactive compound?
Sure. No, great question, Dr. Lasser. So THC, delta-9 tetrahydrocannabinol, can make one high, but it can also make somebody psychotic. And CBD, cannabidiol, is not intoxicating, so it does affect how you feel, but THC is associated with the high.
Mm-hmm. Now, how common is cannabis and cannabinoid use for medical purposes among our patients?
It is more common than one might think. So data indicate that about 27% of adults in the United States and Canada have used cannabis for medical purposes, and about a little over 10% have used cannabidiol before for medical purposes.
Mm-hmm. And what are some of the conditions for which cannabinoids have approval from the U.S. FDA, and what are some of the FDA-approved cannabinoids?
So there are 3 FDA-approved cannabinoids. Number 1, dronabinol, which is pure THC. Number 2, nabilone, which is a CB1 receptor agonist. And then number 3 is one particular formulation of CBD. And so dronabinol and nabilone are FDA approved for one of 2 things. Number 1, nausea and vomiting associated with cancer chemotherapy. Number 2, appetite stimulation in certain conditions like HIV. And CBD was FDA approved, one formulation of it, in 2018 for the treatment of 2 pediatric epilepsy conditions, Lennox-Gastaut and Dravet syndrome, and then also an adult seizure disorder, seizure associated with tuberous sclerosis.
And can you talk a little bit about the different formulations and potency of cannabis and some of the associated risks?
Yes. So part of the complexity to this entire debate is that there are numerous ways in which one can use cannabis. So people are probably most familiar with cannabis flower. So people usually will smoke cannabis flower, but you can also have edible forms of cannabis. You can vaporize cannabis, so heat it rather than smoking it. And there also are ointments that people can make. So there are a host of those formulations, and each one of them has different potencies and different onsets of action. So really the key issue with the various formulations is the THC content. And one thing that we've seen over the years is that all of the formulations, by and large, the potency of these formulations has increased significantly over the years.
And what are some of the risks and contraindications to cannabis or cannabinoids for medical use?
There are both acute and chronic adverse effects associated with the use of cannabis for the most part. There's some problems associated with CBD as well, but most of the problems associated with cannabis are related to THC. So acute risks can include poor judgment. You certainly can have acute intoxication, which can affect not only judgment, but your motor abilities. It can make one tachycardic, and one can have an acute transient psychosis. However, the issues that we're most familiar with are really the chronic effects of cannabis. And so those are usually associated with people who are using daily or near daily. And if one is using in that way, then there are a host of adverse effects related to the brain. One can become addicted. So data indicate that over a third of individuals who use cannabis these days develop a cannabis use disorder. One can have cannabis hyperemesis syndrome. One can have worsening of a host of psychiatric conditions that we could get into if you'd like. And then another issue is that over the years, the physical impact of chronic cannabis use has become more well-defined as well. So there are several cardiovascular adverse effects, pulmonary adverse effects, and then chronic neurocognitive effects as well.
Yeah, that's really helpful. Now, we know that many of our patients are using cannabis or cannabinoids for treatment of medical conditions and for conditions other than those approved by the FDA. So I'm wondering if you could talk a little bit about some harm reduction strategies that clinicians can discuss with patients.
Absolutely. One of the major issues here is that people are always interested in treating chronic medical conditions. People are suffering and they're hoping for better ways to treat these conditions. And so many people are using cannabis and cannabinoids for conditions where, unfortunately, there really isn't a lot of solid evidence. And so in those instances, we encourage clinicians to be able to have sensible, evidence-based conversations with their patients. And if they're definitely decided that they're going to use cannabis or other cannabinoids, we want them to understand that if that use is going to take place, it should not occur concurrently with alcohol or benzodiazepines. We want people to, if they're going to use these compounds for medical conditions, we want them to understand that we want to start with a low dose, as low as possible. And if you are going to increase the dose, increase that very slowly. Another key issue, as more and more states have cannabis policies, we want people to understand that cannabis can absolutely adversely affect one's ability to drive. Mm-hmm. And so I think one of the major reasons that we wanted to come up with a manuscript like we did was that we understand that the train's left the station and this is what people want. So we want to have better informed consent. We want people to understand both the benefits and the risks of these compounds if they're thinking about using them.
Certainly, that's important. Now, you've touched on this a little bit before, but when should clinicians become concerned that a patient may have developed a cannabis use disorder?
Sure. So cannabis use disorder, which for people who are using medically can occur in about 29% of those individuals. So it's a pretty significant percentage. So if someone's using cannabis daily or near daily, then the clinician needs to be alert to be looking for certain signs. And what might they be? Number one, tolerance. So needing more and more cannabis to get the same effect. Sometimes people may have withdrawal symptoms that occur if they abruptly stop their cannabis use. And then the other issues that are associated with cannabis use disorder typically involve people spending more and more time procuring cannabis or using cannabis instead of fulfilling key responsibilities that they may have in regards to work, school, and relationships. So I think that for any clinician that is working with a patient that's using cannabis or cannabinoids for therapeutic purposes, they have to be aware that developing an addiction is a possibility. Most people won't do that, but clinicians need to be aware. They need to be on the lookout for this to occur.
Yeah, and your article included a really nice table that listed a number of factors, and if your patient has 2 out of the 11 factors occurring within a 12-month period, that would help you diagnose the use disorder. Is there anything else generalists should know about therapeutic use of cannabis and cannabinoids that we haven't talked about?
Well, I think it's important to point out that in the context of changing cannabis policy, things have changed in terms of the science. So again, most states have medical or recreational use or both. As we're having this conversation today, we've got 38 states in the United States that have medical cannabis policies. We've got 24 states that have legalized the recreational use of cannabis. So cannabis use, although it may have seemed ubiquitous before, it is on the rise. And with that rise in cannabis use, we have seen concurrent increases in potency, as I alluded to before. So typical potency of cannabis in the 60s, 70s, or 80s may have been 3 or 4% THC. Nowadays, the published data, so Mahmoud El-Soli at University of Mississippi, his group published that typical cannabis potency is at about 20%, so just below 20%. So that's a big difference. And then a really critical thing that I think clinicians need to be aware of is that the percentage of adult users who go on to develop a cannabis use disorder has changed over the past several years. So if we were having this conversation 5 years ago, I would have told you that data indicated that 10 to 30%, and I would have said it's probably closer to 10%. But Beth Hahn, an epidemiologist at NIDA, published a paper in JAMA Psychiatry earlier this year, and they put that number, adult users of cannabis who go on to develop cannabis use disorder, at 34.8%. Mm-hmm. So no matter how we slice it, there are more people using and more people developing a cannabis use disorder. So there are many adverse effects of cannabis, but addiction itself is on the rise. And unfortunately, we don't have great tools to treat cannabis use disorder.
And one last question. Are there any particular concerns with use among adolescents, given that their brains are not fully developed?
Absolutely, Dr. Lasser. So brains are developing into your mid-20s. Mm-hmm. So the data are pretty clear that early and regular use of cannabis, so importantly, I want to underline that. I'm not talking about once a week or once a month. I'm talking about young people who are using daily or near daily. There's pretty clear data that it can affect their cognitive abilities. In fact, there was a paper that came out 2012, Proceedings of the National Academy of Sciences by Madeline Meyer and her group, that showed that early and regular use of cannabis led to up to an 8-point decline in IQ over time. And that's more than a standard deviation. So that's significant. Although all of these, the studies that we've talked about today, many of them are debated because there's so much at stake in the cannabis debate. To me, I think it's very clear that for our young people, they need to be aware of the potential risks of deciding to use cannabis in a regular way.
Well, thank you so much. This has been super helpful. I'm Dr. Karen Lasser. I've been speaking today with Dr. Kevin Hill from Harvard Medical School about therapeutic use of cannabis and cannabinoids. You can find a link to the article in this episode's description. This episode was produced by Daniel Musisi at the JAMA Network. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com or search for JAMA Network wherever you get your podcasts. Thanks for listening.
This content is protected by copyright by the American Medical Association with all rights reserved, including those for text and data mining, AI training, and similar technologies.